Thank you for allowing me to present this evening. I'm Dr. Marere, and I'm just going to go over vaginal hysterectomy. This topic has already been covered by Dr. Shava. I think I joined one of the meetings where he was presenting on the vaginal hysterectomy. So some of it may sound like something that you've already heard before, but I just put it in for completion. As a way of introduction, I'm just going to, you see that slide, I think it's broken. Anyway, let me try and do that. That's the outline of my presentation today. I'm just going to go over the background. I think vaginal hysterectomies go through the role of prophylactic bilateral salpingectomy at hysterectomy. Then I'll just go step by step just on how to do a vaginal hysterectomy, sharing experience on some of the cases that we've done in the recent past. And then I will just go over collecting local data. I think that's where we'll spend most of our time in discussion in this meeting. So hysterectomy is one of the most frequently performed operations worldwide. And it's noted that in the US, they have at least 600,000 hysterectomies that are performed. And these are performed via different routes, which can be vaginal, abdominal, laparoscopic, or with robotic assistance. The commonest route, however, is abdominal, accounting for 66% of the hysterectomies, and 22% are vaginal. And this is based on US data. The most common indications in the US are for symptomatic leiomyomas, endometriosis, and uterine prolapse. So coming closer home, thanks to Dr. Shava, I saw this article published in the Central African Journal, July 2004, where he was looking at complications arising from vaginal hysterectomies and was just observing any complications related to the procedure. They looked at 124 consecutive women who had vaginal hysterectomies and looking at what were the major complications there, including the duration of operation, hospital stay, intra and post-operative complications, need for blood transfusions, and they looked also at the histological diagnosis from the specimens that had come out of the hysterectomies. And they did find out that which is comparable to the US. Actually, most of the hysterectomies are due to leiomyomas, bleeding problems in women, menorrhagia, and the most common risk factors of complications were previous cesarean delivery and other people that had other patients that had medical conditions and previous tubal ligation. So this was just a summary. This study was carried out over 5 years, and this was done in South Africa, Gauteng province. And then coming closer. Coming closer to home. Can you hear me? Hello? Okay, someone you can mute the okay, thank you. So then coming closer to home, I did come across this article yet to be published, which was a study done by one of our registrars from the Department of Pathology. And this was carried out in 2019, over the year from January to November 2019. And they basically were looking at all the specimens that had been submitted for histology. And these specimens were uteri from a hysterectomy, from whatever reason. So these were some of the indications for the hysterectomy that they put down. They actually received 350 specimens over that year. And these specimens were coming from Parenyatua group of hospitals. They were coming from Salim Mugabe Hospital, which is former Harare Hospital. They're coming from Mutare Provincial and Chinhoyi, most of them. And this is what they found. So they found that most of them were uteri that were coming in post-hysterectomy with leiomyomata, which is about 47% of the cases. Some of them, this was followed by specimens that were submitted secondary postpartum hemorrhage, and this was 18%. this one made me a little bit worried. We'll discuss that later. And then, of course, cervical cancer, 3%. I'll just highlight the ones that were a bit common. Chronic pelvic pain, 6%. So they were trying to look back into the NIST to see what were the indications for these hysterectomies. And some of them were due to high-grade squamous dysplasia of the cervix, as you can see. And basically that's what they found. And uterine prolapse only accounted for about 1.5% of these specimens. So from this study, they summarized that the results showed that most of the patients were between the ages of 41 and 50 that had undergone a hysterectomy. Leiomyomata was the most common indicator for hysterectomy, together with postpartum hemorrhage. Total abdominal hysterectomy was the most common operation performed, which was the route of hysterectomy done in most of the women. And most of the samples had been submitted from perinatal group of hospitals and from Mutare as well. So basically, factors that surgeons consider during when choosing a route. When choosing a route for hysterectomy, sorry about that, to do with safety, cost effectiveness, medical needs of the patient, and the body mass index. Some of these are relative, some of them may make the surgeons choose otherwise. And more factors to consider include surgeons' training and experience when it comes to doing a vaginal hysterectomy, accessibility of the uterus, mobility, extent of extrauterine disease, if there is, the size and the shape of the uterus, the need for concurrent, sorry about the typos, need for concurrent procedures, and the patient preference. So this was just a study where they looked at over 2,000 women in the US, again based in the US, where they were just comparing the outcomes in the different routes for hysterectomy. And they looked at just the very obese and the morbidly obese women that had a BMI over 35 kilograms per square meter. And in this series, they noted that abdominal hysterectomy was associated with more post-operative complications like wound dehiscence, wound sepsis, and a longer hospital stay. This is just a list of some of the contraindications to vaginal hysterectomy. And these include pregnancy for obvious reasons, cancer, obvious reasons where you are worried about spread or worried already that there's extrauterine disease. And some of the relative contraindications include an enlarged uterus or very bulky uterus above 12 weeks, nulliparity, a narrow vagina, a narrow pubic arch of less than 90 degrees, and of course an immobile uterus. Other concerns also include, as highlighted earlier, adnexopathology, so where you have enlarged ovarian cysts or other things like adhesions, severe endometriosis, then you may reconsider doing a vaginal hysterectomy. So basically, with an enlarged uterus, vaginal hysterectomy can still be safely done by morcellation, uterine bisection, wedge debulking, intramyometrial coring. We'll discuss these a little later just now. So this is just a flow diagram to just illustrate how some surgeons can sort of like come up with a plan in terms of deciding on which route to use when doing a vaginal hysterectomy. So basically, we know that vaginal hysterectomy is natural orifice surgery, which is probably the preferred mode of doing a hysterectomy, where the indication for the hysterectomy is for a benign disease. So this flowchart is just assisting us to see how we can possibly decide whether it's safe or unsafe to achieve a hysterectomy via vaginal route. So basically, you'd say that if the uterus is accessible transvaginally, then yes, you can proceed and check the size of the uterus. If it's less than 12 weeks in size, if the pathology appears confined to the uterus, then it is straightforward that you can actually attempt a vaginal hysterectomy. If you think that the uterus is too big, it's more than 200 grams in size, it's more than 12 weeks in size, then you have to decide whether you think that you can possibly reduce the size during the surgery. In which case, if you think you can, then you can attempt to do a vaginal hysterectomy. If you think you can't reduce the size, then you'd rather go for abdominal surgery. If the the pathology appears not confined to the uterus, then you may want to do a laparoscopic examination and check if there's extrauterine pathology, which is there, or it's very mild. In which case, if it's very mild or absent, then you can proceed with the vagist. Or if it is there and if there's extrauterine pathology, then you check if you can access the cul-de-sac. If you can't, if there's severe adhesions, if there's severe endometriosis, then you can either do operative laparoscopy or go the open route and do a laparotomy, the abdominal hysterectomy. So this is just a quick flowchart that just can assist you make a decision as to how best to choose the route for hysterectomy. So this was just a Cochrane review by Niba and others published in 2009, where they looked at, I think these were more than 5,000 cases, and they were just basically comparing the different approaches to hysterectomy, where they were just highlighting basically the advantages of a vaginal hysterectomy versus an abdominal one, and the advantages of a vaginal hysterectomy versus a laparoscopic one. So with the vagist versus an abdominal, you find that there's a shorter duration of hospital stay, there's a faster return to normal activity, and there are fewer febrile episodes or unspecified infections. This is what they found. And then when you compare vaginal hysterectomy with a laparoscopic one, a vaginal hysterectomy was associated with a shorter operating time. Yeah. So then we'll move on to consenting for a vagist. How do we do this? So when you want to then obtain consent from a patient that you think is suitable for this procedure, then you have to discuss with them at length on the different routes that are available so that they also make an informed choice, so that they can also choose if they prefer a certain method, then they're allowed to choose. Discuss the various advantages and disadvantages of each approach, the possible complications that can happen both intra and post-operatively, including the possibility of you actually converting the operation from a vaginal one to an open procedure where you're doing a laparotomy basically. Then also discuss with the patient the issue about opportunistic salpingectomy, bilateral salpingectomy at the time of the vaginal hysterectomy. Also discuss possibility of oophorectomy in the case of abnormal ovaries, and then also discuss sexual function post-operative to allow the patient to make an informed choice. I just put up that slide just to just tickle you a bit on the role of prophylactic salpingectomy, which is the opportunistic salpingectomy that is offered to all women that are undergoing a hysterectomy for a benign indication. So we know that ovarian cancer has the highest mortality rate among all the gynecological cancers. So the question there that had arisen was, should all the women who are undergoing a hysterectomy for benign indications be offered bilateral prophylactic salpingectomy? So I just looked at that meta-analysis from the European Journal of Cancer that was published in March 2016, where they're looking at bilateral salpingectomy as a way of reducing the risk of ovarian cancer in the general population. So these were the highlights, where they then noted that bilateral salpingectomy actually reduced the risk of ovarian cancer by 49%. And they've said it's an effective measure to reduce ovarian cancer risk in the general population. This procedure could avoid the development of consecutive tubal pathology. This procedure also did not have any short-term deleterious effects on ovarian reserve. So there was preservation of ovarian function. So they then said this should be considered for women requiring hysterectomy for any benign indications to reduce that risk. And they concluded that the results suggest that removal of the fallopian tubes is actually an effective measure to reduce ovarian cancer risk in the general population. Therefore, prophylactic bilateral should be considered for women who require hysterectomy for benign indications. We can discuss this later anyway. So we move on to the subject of the day, where we just want to go quickly, step by step, vaginal hysterectomy. So basically you prepare your patient, preoperative assessment and preparation. Anesthesia can be regional or general. Regional, sometimes you may use in patients that you think unsafe to put to sleep. So if they've got severe cardiac disease or you think that it's unsafe to put them to sleep, then you can consider regional anesthesia for a vaginal hysterectomy. Go through your theater checklist to check your equipment, to check that you've got the instruments that you require for this procedure. And for today, we'd require that you have myoma screws, 2 of them. You have the vaginal speculums, the SIM speculum. You've got your lateral vaginal wall retractors. I found also divas to be useful, the small and the medium divas. In this case, women may be at risk of getting thromboembolism. So also advise that they use the TED stockings or the intermittent pneumatic compression devices that can be used intraoperatively. So as you start, you actually put your patient to sleep, then you re-examine just to check your anatomy again, check the findings that you had noted preoperatively. Sometimes these may change. So it's much easier and the patient is relaxed. So you check the uterine size. Is it mobile? Is it coming down? Is there any disease in the adnexia, in the pouch of Douglas? Is all of that free? Check the pubic arch angle. Do you think that the pelvis is adequate for that procedure, especially where you have enlarged uteruses or uteri? Then you hold your cervix with whatever you have, tenaculum or forcellum, and then you can inject the cervical fluid, which can just be normal saline, which can be with lidocaine or vasopressin. These ones are not, they go according to the surgeon's preference, basically. And then you make your incision on the vagina. So I'm just going to be sharing some of the pictures from a hysterectomy that we did last week, mid last week. This was a patient that presented with menorrhagia for the past year. And she's 42 with multiple fibroids with a normal pap smear, which had been done the year before. So she was complaining of symptoms of anemia, basically, and she was very ready for hysterectomy. She was para 3. All of them had been normal delivery, so she didn't have any prior abdominal or pelvic surgery. So we examined her uterus was about 14 to 16 weeks in size. Prior to the operation, she had been said to have multiple fibroids, with the largest about 6 centimeters in diameter. So I'm just going to go through the steps and then show some pictures. I managed to get those pictures, and I want to appreciate the team that I was working with. I was with doctors, Nema Chena, Dr. Chimundo, anesthetist, and some of the cases I'll refer to them as well, with Dr. Kurisa and Dr. Chamunyonga. Thank you to those guys and allowing me to share in this presentation. So you make a circumferential incision at the level of the vaginal rugae, basically, and this one involves the full thickness of the vagina. If there's accidental cystostomy that occurs during this, then you may as well proceed with the hysterectomy and then repair the bladder afterwards. We can discuss some of these as at the end of the presentation. Then we identify the posterior peritoneum. Then the peritoneum is grasped with tissue forceps and incised with the myoscissors, and then the weighted speculum is then inserted into the posterior cul-de-sac. So this is a picture just demonstrating that first step there, where you just want to expose the posterior peritoneum. So sometimes you see it as a bluish tinge. I think it can be a bit clear on that picture. I don't know if you can see my picture as well. Dr. Nyakura. Hello?
Yes, we can see.
Okay. All right. Thank you. So you can see there, just opening up the posterior peritoneum so that we can get into the pouch of Douglas. So once you get in there, as we did in that picture, we then put in in this case, we're using the diva, putting the diva into the pouch of Douglas so that you can expose your uterosacral ligaments, which would be the next step. So the next step then that you deal with the uterosacral ligaments, identify, clamp, cut, and tie these ones. The suture then is held with a hemostat to help locate the bleeders later on before you close the vault at the end of the procedure. So that's the first step. So this is just demonstrating us doing that on the patient's right side. Then the next step would be to do the cut. Hello? To do the cardinal ligaments. So these ones you identify again, clamp, cut, and tie. It's good to note that other devices that use electrocautery, like the Ligashow, Covidian, they can be used actually in vessels that are up to 7 millimeters in diameter to actually do this kind of procedure. But in our case, we were using the sutures. So you use a single clamp technique to reduce the risk of urethral injury, incorporating both the anterior and the posterior leaves of the visceral peritoneum. And this is what was happening in this slide. I don't know if it's very clear. It was difficult. I think the lighting was too much. I only just realized that, but that's the next step where you do the cardinal ligaments. Then thereafter, you then start to try to deliver. So each time you're doing these pedicles, you can actually feel that the uterus is actually descending. But sometimes if it's an enlarged uterus, then you may feel that there's not enough space for you to maneuver or for you to then do the other pedicles. So in this case, then you start to deliver the surgical specimen. And this is where we're going to demonstrate using the double myoma screw technique, where I think I'm just going to try and play that video, try to show it there. I don't know if it's going to play. Okay, I think, can you see it?
Yes, it's playing.
Okay, thank you. So that's where you put the myoma screw either into a fibroid at the back of the uterus, and then you try and pull cephalad so that the fundus of the uterus is delivered. So in this case, we actually just had one myoma screw, which we managed to pull the uterus, and then we ended up using the lens forceps to try and grasp the fundus of the uterus so that we could deliver the uterus. So this became quite difficult because the uterus was very bulky with fibroids. So we ended up actually doing a myomectomy. We ended up removing one of the bigger fibroids that was fundal, and this was about 5 centimeters in diameter. We did a myomectomy, and then the uterus delivered. Then after that, we proceeded. So then you identify your utero-ovarian ligament, clamp it and cut it. So double ligate first with a suture tie, and then with the suture ligature medial to the first tie, just so that you don't puncture vessels. You also place a hemostat to assist in identification of bleeders later on. Then you remove the adnexia if you plan to remove so. If you plan to remove the ovaries and the tubes and the like, then you do so at this stage. I think we've shown that already. So I just put up that slide back again to say, so how would you then deal with a very enlarged uterus during this kind of operation? So you can employ emulsion if you've got the equipment, and you can do that to try and remove, especially with the enlarged fibroids, but taking care not to then damage the surrounding structures, the visceral structures. You can also bisect the uterus, that's uterine bisection, in half from the cervix going inwards, so that you can also create space for yourself. You can do wedge debulking. You can do intramyometrial coring. So this we had to do in the first patient we did about 10 to 14 days ago. This was the morbidly obese lady with comorbidities. She was diabetic, she was hypertensive, and the BMI was about 45. We actually managed to put her to sleep. So this was done under general anesthesia, but she had the bulky uterus coming to about 16 to 18 weeks in size. And she had the largest fibroid was about 11 centimeters. So we actually had to do intramyometrial coring to try and deliver to do a myomectomy, which was quite difficult. So we managed to do it piecemeal, but at some point we almost then converted to a laparotomy, but we managed to then remove the 2 big fibroids. And after that, then the uterus fit, and we managed to proceed with the vaginal hysterectomy. So sometimes, like I said, in this case that I'm showing, you'd have to do a myomectomy first, just so that you can create that space. So this was the uterus after we did the myomectomy, and it managed to deliver. Then using your finger there, you can then identify your infundibulopelvic, and then you can do that last pedicle there. You can see that on the patient's left, and then you proceeded to the other side, which is the patient's right-hand side. Yeah, I think you can see it clearly there. And you can even see on the other side, that's the ovary, which we left in, because this patient was 42. In this patient, we didn't do a prophylactic salpingectomy. We left the tubes and the ovaries inside. And then as you end your procedure, then you want to inspect all your pedicles. Use your sponge stick placed in the peritoneal cavity, to visualize all the pedicles, check for hemostasis. And then you can use the suture to ligate any bleeders under direct vision, best to avoid any energy, because you may then damage structures nearby like the ureters, bowel. And then you can do a purse string around the peritoneum to exteriorize all the pedicles, which we didn't do in this case. We just then proceeded to close the vaginal vault. So bring the posterior peritoneum and the post-vaginal skin together. This we did to reduce bleeding posteriorly. So you find when you're trying to enter into the pouch of Douglas, sometimes some surgeons use their fingers, sort of like a blind entry with their fingers, which can sort of like create a track, and that area that you create between the peritoneum and that vaginal skin can give you troublesome bleeding. So if you just pick that posterior peritoneum and bring it to the vaginal skin together, that can help with that bleed. Then you close the vaginal epithelium vertically or horizontally with continuous or interrupted sutures. In our case, close the vault horizontally with continuous sutures, and always try to avoid the bladder. So you find that some surgeons put an indwelling catheter at the beginning of the surgery and keep it until the next day, which is 24 hours post, to try and reduce damaging the bladder, to always make sure the bladder is empty throughout the operation. Some surgeons prefer to just empty the bladder at the beginning of the operation, and they leave the patients without a catheter and discharge their patients on the same day. Some surgeons actually prefer not to even empty the bladder. They prefer to have the bladder full as they're operating. And to justify this, they say they just want to be able to identify any injuries quicker. So for example, if you end up in the bladder cystostomy, you can easily see that you've damaged the bladder because you didn't see the urine. So this was the specimen after the hysterectomy. That's the fibroid there, and that's the specimen that we had. That's the uterus and the cervix. We managed to weigh this uterus. It weighed about 160 grams after the operation. And this is us looking into the peritoneal cavity to identify any bleeders from all our pedicles. So you can see those are the sutures from the right, and the others on the left a bit hidden inside. So it was dry. So we proceeded to close, and then that was us closing the vault. So at the end of it, you do a cholecystectomy to reduce the risk of enterocele, reduce the risk of vaginal vault prolapse with time. And there you can employ either the Moshkowitz repair or the Markos cholecystectomy. Basically, these are trying to just pull together the cardinal and the uterosacral ligaments and tie them in the midline so that you close off that space and you elevate the vaginal vault to reduce the risk of prolapse in the future. So in terms of complications, this is just a summary really, just highlighting the commoner things. Intraoperatively, you can get visceral damage. Remember, the bladder, the bowels, the ureter is very close to where you're operating from. And from a series in the US, they just put their risk of ureter damage to 0.88, and that of the bladder was slightly over 2%. And postoperatively, most of the common complications are to do with pelvic sepsis. That's the most common in 4% of the cases, where women can get a febrile illness, they can get urinary tract infections, pelvic cellulitis, and even a frank pelvic abscess. What's more common is a vaginal cuff cellulitis. They can get sometimes vault dehiscence if you're using too much energy around that area, or if your sutures are too tight. So if there's too much tension, that can also deter healing. And you can end up with vault dehiscence. And long-term, if you do not meticulously bring together the uterosacral cardinal ligaments for support, then you can end up with vault prolapse. And these women can present months, years down the line with vault prolapse. So this was our patient. She did quite well. She stayed in hospital for 2 nights, removed the catheter the next day. She had clear urine, was passing urine well, bowels opened on the second day. We stopped antibiotics on the second day, and she went home. She, however, complained of constipation about 5 days post-discharge, and we just ordered some glycerin suppositories, and that seemed to work. And her bowels are open now, and she has no complaints. Blood loss was around 300. She bled a little bit, at the beginning of the surgery. even after infiltrating the saline, she was oozing quite a bit, and used a bit of diathermy to try and coagulate those bleeders, but she didn't require transfusion. The post-op hemoglobin was sitting at 11, so she didn't actually lose too much blood, but it was quite a bloody field. It wasn't as dry as the other ones. But otherwise, she's done okay so far. No problems, no complications that we've taken note of. I will see her after 2 weeks from today, actually. She's due to come in for a review. So that's the case that we did last week. The other two were the more difficult ones because the uteri were much bigger. Unfortunately, we didn't manage to measure the weight for the bigger lady. She was more below base, but we realized that if we'd even done a laparoscopy, it was going to be difficult to see the pedicles from, because the uterus was filling the whole of the pelvis. The fibroids were big. And if we had done an abdominal approach, we were worried about wound sepsis, dehiscence, because she was very big. So in hindsight, probably it was the best thing to offer a vaginal hysterectomy, although we're now worried whether we're going to damage surrounding structures because it was a big uterus. So if we'd actually known how big it was, I think we would not even have done a vagist. Would probably have just then gone for the abdominal surgery. But we thank God that it worked out in the end. So why I am talking about vaginal hysterectomies today is that Dr. Shava has nudged me quite a number of times, and he's really supported our teams here as we're doing vaginal hysterectomies to just be a bit more confident. And we've managed to do some cases and are quite happy with our progress so far. So he suggested that we do not actually have current data from our locality. So we actually do not know even just the indications for hysterectomies that are being done in this part of the world, the routes. So in this case, we're just trying to go and zero in just on the vaginal hysterectomy per se and see what our outcomes are, what our indications are, what's the morbidity, mortality, whatever is like that is coming with the vaginal hysterectomies that we're offering our patients in this part of the world. So we've created, with his help, this data sheet, which I'm hoping at the end of this discussion, we can adopt, we can click, we can add, subtract, so that it becomes a document that we can put on our website so that all of us can enter our patients that would have offered a vaginal hysterectomy. So this will be like an ongoing, it's like a live page where after your hysterectomy, you actually enter your data and then you keep updating that, and then it carries on so that at the end of the year, perhaps we have with that 200, 300 hysterectomies that we can actually look through and analyze and see what we are actually doing. So on the sheet, we'll have the usual demographics, age, marital status of the patient, their profession, level of education, residence, where they're coming from, are they coming urban, rural, peri-urban, then a bit of their gynae history, their parity, if they had previous abdominal pelvic surgery, have they had a previous cesarean section? If yes, then you just state the number of previous cesarean sections. And then we're looking at the current problems, why they're actually coming in for that particular intervention, which is basically the indication for the vaginal hysterectomy. Are they fibroids? Are they bleeding heavily, menorrhagia? Is it chronic pelvic pain, endometriosis, pelvic organ prolapse? Or if there's any other reason, then you can put it down under other. I think we'll add that as we revise the sheet. And then we go on to document the preoperative assessment. First of all, do the general assessment, just do a full blood count. If you want to add the urine electrolytes, check the pap smear result and document it, their weight, their height, calculate the body mass index, and then do a pelvic examination where you're just checking the uterine size on palpation, check the mobility of the uterus, the size of the pubic arch angle, then jot down the ultrasound scan report in terms of the uterine size and any major findings. For example, is it a multiple fibroid uterus, the ovarian cysts, whatever else that the scan picks up before you offer that operation. Then you're going to document your intraoperative findings, where you document the type of anesthesia that was offered. Is it general? Is it regional? The number of surgeons. Is it one surgeon? Is it two surgeons? Cervical length, pouch of Douglas, presence of prolapse. Is the vulva gapping? So you just put a yes, no, you just document what you found, confirming. And then after the patient is put to sleep, you're also going to confirm your preoperative findings. So confirm the actual uterine size, because now the patient is relaxed. You can check that. You can check the mobility. You can check the pelvic adequacy again. Then after your procedure, you document the blood loss. Was there any visceral injury? If so, then you document your paths of care. I mean, if you damage the bowel, did you then call in general surgeons, colostomy, blah, blah, blah? Did you look for urologists if there's bladder, ureter injury, blah, blah, blah? And then you also then document at the end of your procedure whether there's urine in the bag or absent, and also the color of the urine. Then you measure the uterine size objectively and the weight as well before you submit the specimen for histology. Also comment on the state of the ovaries, whether you removed them, left them in there, state of the fallopian tubes, whether you did a salpingectomy or left them in there. And then if you did a bilateral salpingectomy, just say yes, no. If you did an infectomy, yes, no. Surgical time of the operation itself, and then also document any other complications. And also then if you converted to a laparotomy, also state yes and no. Then you do the post-operative assessment. You document 2 hours post-op, whether there was urine present or absent, the color off, was there any vaginal bleeding, was there any other problems? If there are, you just document the course taken. Day 1 post-operative, you check again, is the urine present, absent, in the color? Then you then remove the catheter. Check if there's bleeding from the vault. Just document whether the patient required transfusion, yes or no. Is the patient mobilizing, yes or no? Analgesia requirement, just give a comment whether they needed extra analgesia or they actually declined. And then diet, were they feeding normally? Then day 2 post-operative, do a checklist again and check. This is the day generally that we're saying we should discharge our patients after a vaginal hysterectomy. So discharged, yes, no. If not, then you give the reason why not. Is the patient mobilizing? Are they feeding well? Check on their bowel habit, check on their bladder habit. Are they passing stool? Are they passing urine well? Is there any bleeding from the vault? Do they have any fever? Document the hospital stay, and then also just document that you've given them the instructions that they can drive, work, resume sexual activity when. Then you document that. Then I put that again as day 3 from the time that you discharge them to day 2, which is 6 weeks post-operatively. Just check and document whether they developed any foul-smelling discharge from the vagina, any bleeding from the vagina, any other complications and the interventions. Document any morbidity, for example, ICU admission and the reason. Document any mortality and the reason. And then follow up on the histology. Follow up on the histology and document the final diagnosis. Was it adenomyosis? Is it leiomyoma? Is it cervical cancer? Whatever it is, then we document that as the final diagnosis. Then at your review at 6 weeks, also then check the vault and comment on the status. Is the vault healed completely? Is there a bit of dehiscence? What is going on? Check the bladder habit, bowel habit, and then from there you can then say discharge from care, yes or no. If no, then you give the reason why you cannot discharge that patient at that point. The other thing I was going to add is just maybe follow up if we're able to follow them up a year later, just to check if there's anything, for example, vault prolapse or any other problems that you think may be related to that operation. So that's what I prepared for today. And yeah, I think I will end here and pause and allow people to ask and comment. Thank you. Hello.
Thank you so much, Dr. Marere, for a nice and comprehensive presentation, very practical, and also giving us some work to do. I really like the end of the presentation where we're like trying to collect uniform data so that we'll all be able to assess it at the end of the year. I really appreciate that. Perhaps I have 1 or 2 questions for you. The first one, I think you have partially answered it already. So when I was in Harare with the vaginal hysterectomy, we would always empty the bladder and then proceed with the vaginal hysterectomy. When I came to V4, we had an operation theater nurses that had trained at UBH in Bulawayo. When they found me, when they started to see me emptying the bladder, they started questioning me, and they always opted to leave the bladder empty. They said the surgeons in Bulawayo had informed them that it would be easier to identify any bladder injury if you leave the bladder empty. And that's what I am now doing. I found it interesting. So we always leave the bladder empty. I don't know which technique you do prefer, Dr. Marere, from these, whether to leave the bladder empty or to empty to empty the bladder or to leave it full.
Thank you, Dr. Nyakura. So from this end, we just tend to empty the bladder from the start, and we keep the catheter throughout the operation, and then remove the catheter 24 hours post-operative.
All right. Yeah, that's what I was used to. So, but now we always catheterize after the procedure. Interesting. Interesting. And then the other thing, in terms of the literature, have you tried to look at in terms of ureteral injuries? I really find it very difficult. How do we assess for ureteral injury during vaginal hysterectomy? I always find it difficult because you can't see the ureter, unlike with the open surgery, we can't see the ureter here. When we compare with abdominal and laparoscopy, how do we try and identify and actually reduce the risk of ureteric injury during vaginal hysterectomy?
Yeah, that's a very good question, because with laparoscopy, it's good because you can see what you're doing. You can check your ureters after your operation. You can check whether they are moving. You can even do a cystoscopy and check whether the ureters are actually draining. But with the vagist, you just have to stay onto your uterus because it's for a benign indication as much as possible. But afterwards, it's always difficult then to be able to tell that you've injured the ureter, unless, of course, you've got bloody urine and other things that you're thinking, is it the bladder? Is it what is going on? If you think, oh, there's no urine afterwards, remember, you're also going to check whether you've got urine at the end of your procedure or not. Then that can prompt you then to try and check or try and ask for diuresis before you close off and see whether there's function. But you find that if you've damaged the ureter, sometimes then it can then present itself later on. But during the operation, perhaps I can even invite Dr. Shava and Dr. Vuma to comment on how they have tried to identify these injuries during the operation before the patient is awake. Otherwise, we'd have to be checking and realizing these injuries further down after a vaginal hysterectomy.
Thank you so much.
Yeah, good evening. Thanks, Dr. Marere.
Thank you.
Regarding bladder, I think if you are in terms of injuries, usually when you are starting, it's usually better to actually put methylene blue in the bladder. You actually put methylene blue in the bladder and leave it full, so that even if you do get any injury, you can actually identify exactly at what point you have injured it. So I normally would catheterize the patient and then clamp the catheter so that the bladder doesn't empty during the procedure, and then empty it just after the operation. And then regarding identification of the ureter, this is very important, because when you do advanced vaginal surgery, you will learn what is called the click technique, where you act as you are tying your transverse cervical ligaments. You put your finger posteriorly to in between the transverse cervical ligament and the sacrouterine, and then you pull your, I think I did show you when you were doing an EUA, and then you actually feel the ureter click upwards. And then the other thing, like you say, for benign disease, you make sure you take a precaution of remaining medial as possible. But you can actually identify the ureter, particularly if you are going to be removing nodes, because that is, so it's not exactly true that you cannot identify. You should be able to identify the uterine artery. You identify the ureter during vaginal hysterectomy. The only difference is that when you identify the vaginal hysterectomy, you only identify the elbow of the ureter, which you can actually push away as you are doing the procedure. Thank you.
Thank you, Dr. Shah.
Hello, Dr. Marere. Thank you
Yes,
for the
Dr.
wonderful
Vuma.
presentation. I missed some of this stuff. I had to rush and do a delivery, but anyway, I'm still biased towards a laparoscopic delivery, because one of the downsides of vaginal hysterectomy is vision. Has always been a problem. Till we improve vision, we have a problem. But just another point of saying that if you damage the ureter, I think sometimes if you want to check, there's an intravenous methylene blue that you can give. So if you think you have damage, you can just give intravenous methylene blue, and then ask the anesthetic give IV methylene blue, and then flush it with Lasix 20 milligrams, and then at least you don't have to wait long, and you'll be able to identify if you're worried.
Okay.
Because I mean, I've just a colleague that I had the other day now here. He tried to do a vaginal hysterectomy and then managed to get both ureters and the bladder damaged, converted to laparotomy, fixed the bladder but missed the ureters. So unfortunately, then they had a bilateral reimplantation of the ureters. Thank you.
Yeah. Thank you, Dr. Vuma. It's always a challenge. So I was going to also just highlight that if you cannot also get into the pouch of Douglas, into the pouch of Douglas from the start, if it's inaccessible, then you might as well convert to a laparotomy so that you don't then end up not sure of who you are. And rather than from the get-go, as you get your consent, always get consent to cover it. Say if we fail, then we should do a laparotomy so that you don't proceed where you are not sure. So where you can't visualize, you can't see, you're better off doing a laparoscopy.
Thank you, Dr. Marere, for the very interesting presentation. My question is on that slide you presented on the opportunistic bilateral salpingo-oophorectomy. In the study that they did, I know they said 47% reduction in your risk of ovarian cancer. Did they also collect data, or are they collecting data on the subsequent risk of attaining an earlier menopause?
So thank you for that comment, Doc. So I have not seen whether they are doing a follow-up. All I know is that currently there is sort of like evidence which is not yet published. There is upcoming thoughts that it might actually not be beneficial in the general population per se, but I stand to be guided. Still waiting for that to come out. So I don't know what the other colleagues here are doing. I'm just left in a space where I'm just offering bilateral salpingectomy in all women that I'm doing benign hysterectomies for. But if they then worry about menopause coming early, I counsel them that yes, it can happen, but it's not that significant. Then they can make an informed choice, but I'm offering it. But I don't know whether it is it's got evidence. I don't know what the other colleagues think about this. That's why I put that slide. Actually, I just put it up so that we can just quickly discuss it. If there's anyone that has got current robust evidence to support it, then they can share.
Yes, can I just jump in and say, if you look, go back to basics, to anatomy, the ovarian blood supply is very variable, or even the tubal blood supply, you may find that I think there are 5 types, if I'm not mistaken, 6 types of blood supply to the ovary. It can be mainly uterine artery, or it can be ovarian artery. So then those patients that will have premature ovarian failure is when the main blood supply is coming from the tubal artery, from the uterine artery to the tubal artery, not primarily from the ovarian artery. That's from the basics of anatomy. So it may not, because unfortunately when you do it, you never know where the majority of the blood supply is coming from. So that's my only, from basic anatomy. I mean, if you go through the blood supply of the ureter, of the tube and the ovary, you'll find actually there are 5 variations that have been described. And I think that's the basis of premature ovarian failure rather than technique.
Okay. Thank you, Dr. Bvuma, for that. So are you offering bilateral salpingectomy in your patients?
On my side, yes, I am. I think, I mean, as you rightfully said, you discuss it with them. And so far, I think as you say, the data obviously is not randomized controlled studies, but it's obviously from the biochemical, from the thing that actually then from what I read, and that seems to be the standard of care, I think from the people from Kaiser Meeting in America, I think they presented some evidence to say there is evidence to say from a molecular perspective, the studies they did, they say the basis, the origin of ovarian cancer is from the tubal epithelium. So that's the information I also share with the patients.
Thank you.
Dr. Ngwaru?
Good evening, everyone.
Good evening.
Yes, so concerning this bilateral prophylactic salpingo-oophorectomy, I think from basic science, I agree. That's what it says. But I think there should be a study which have shown that it's only beneficial in a certain group of people that are already at risk of developing these tumors. So I think I forgot, because I attended some conference in Cape Town where there was a lady who actually looked at that data, and the conclusion was it's only beneficial in those patients who are at risk of developing that. So when I practice here, I really don't have anything that I can do to screen to say that you are at risk of developing this and whatever. So I still offer, but at the back of my mind, I think maybe sometimes it's not really helpful to them. So where I find it very difficult to do it, I don't. Where I find it easy to do, I do. But I think because in our setting, we don't also do the risk profiling. So we don't really know. We also don't know what killed our grandparents. We don't have this kind of history. So maybe it might be beneficial just to do for everyone here. But I think it's only if we are able to profile, those are the only patients who are going to benefit from prophylactic salpingo-oophorectomy.
Let's welcome Dr. Batel from Israel. Do you have any comment in this discussion, Dr. Batel? We can't hear you, Dr. Batel. And Liseko Sifanyenso, what's your experience?
Hi, good evening.
Good evening.
Evening.
Yeah, Just a few notes from my side. My experience with vaginal hysterectomy is that probably the anterior colpotomy is the most challenging, and once you're in the front, the operation is easy. If you struggle to get in the front, you must obviously try and get in at the back, your posterior colpotomy, which is a lot easier. And you can actually start taking your uterus sacros and transverse cervical without the anterior colpotomy. And I've been able to then get in front by initially getting in at the back and then going up as I reflect the bladder upwards until I'm able to get in front. In terms of uterine size, yes, the bisecting the uterus and coring the uterus is techniques that I've used before that have helped me. And yes, the size of the uterus is a big challenge, but I find that mobility for me is more important than the size. And obviously, you've got to have your own limit on what size uterus you would attempt a vaginal hysterectomy on. One thing that I've found very helpful in one of my patients that I did is that if you're worried and you find that at the end of the procedure you're uncomfortable with hemostasis from below, there's absolutely nothing wrong in putting a camera at the top to check and make sure that your pedicles are dry from the top. It literally doesn't take such a long time, and it makes you sleep better at night that you're able to see from the top that you achieved hemostasis. That's it.
Thank you. Dr. Patel was trying to get through to us, but she says she's on call and an incoming call came, so she couldn't. Dr. Gwanzura.
Sorry, another comment. I operated recently with a colleague who, besides opening the pouch of Douglas, also opened anteriorly before starting to ligate the pedicles. I found the surgery a bit bloody. What are your thoughts on that approach?
Right. I think my opinion on that approach is very straightforward. I do not recommend that we open the anterior part of the bladder, particularly if you are going to do it in previous surgery or in large uteri. You don't actually know where the bladder starts, and there are clear landmarks regarding the pouch of Douglas.
In progress.
Oh. No. Hello.
Hello, we can hear you. I think
yes.
there are two people who need to mute.
Okay, so I don't think opening the anterior, it's useful when you are dealing with a very small, small uteri. But if the uterus is big or you have got previous surgery, that's actually the best way you can actually injure the bladder, and it's best to avoid it and make sure you actually dissect the bladder posteriorly with a method where you sort of flex the uterus with your last myoma, like what Dr. Marere was showing, and then you can actually see the bladder, and then you cut it off rather than open it blindly. The anterior is like what Sifanyetso is saying. The anterior the anterior, opening the anterior pouch is actually much harder than the posterior pouch. And as a rule, I always start with the posterior pouch. And if you cannot get into the pouch of Douglas, that should be a sign for conversion. And you should not waste time. You should just convert. Thank you. Do we have any burning comments, questions? Hello? Hello?
Hello.
Yes, I'm saying, do we have any burning questions, comments? Because I think our time now, we are way past 7 o'clock.
None from my end, thank you.
Thank you, Dr. Shava. Thank you, everybody, for the contributions. I just wanted to then say maybe on the platform, I'm going to send that data collection sheet before I ask Twende to then upload it onto the website for us to start putting our data there, if you're all in agreement. So I'll send it, then you can always then say, I'm going to send it the way that it will look like. So I'm going to put it the way that you will fill it in, basically.